Sama, for your kind words. Sabah al-khair, assalamu alaikum. It's my pleasure to be with you today. I would like to thank you for accepting our request to have our presentation with you here as part of our activities for the month of childhood cancer awareness. I would like also to thank Smile Initiative Group. There is a representative here, Fatima, to let me to be a volunteer member with them since many years, since 2011, and for their great work they are doing it. They did and they are doing it for our kids and their families. So the title of my topic is "Children are not small adults. Be aware of childhood cancer." I chose this title first to attract people from here, because I know most of the attendants, maybe they are not pediatrician. So that's why I add the word of adult. And second, because it's true, children are not a small adult. They have different characters. They have different and unique exposures, dynamic developmental physiology, and they have longer life expectancy. That's why it's something important to consider it when we look at these kids and treat them. And they are also politically powerless, which affect the research part and the donations and others. So in the coming 45 minutes, I'm going to present at least 16 facts about childhood cancer, which cover different aspects about that disease. I will start my presentation with this question to you. Any guess? What is the color of childhood cancer, Raibon? Any guess? Gray is a brain tumor.
Yellow.
Purple is epilepsy. It's a gold color. That's true.
You know why? Because you are wearing it.
I will hide it. Gold color. Gold is a very precious metal, and that's so our kids are very precious things in our life. That's why it was chosen for that. So the first fact about childhood cancer is a rare disease. And we define a rare, that means it affects less than 5 persons per 10,000 of population. And that's true when we come for childhood cancer. So among all the ages, we can find the two lines here, the green and yellow. This represents only child cancer. So it is less than 6%. If we consider children up to the age of 14, which is currently here. But sometimes in some centers, they add also the adolescent up to age 18. So in this case, it will be around 12%. So still it is low. And 50% of this group will be those who are under the age of 5 years, which are the preschool, which means these kids are, they cannot express their symptoms, and they will depend on the caregivers as well as the maybe medical doctors who assist them for any other reason to discover any signs or symptoms of childhood cancer. If we come to numbers in adults, annually there will be at least 18 million new cancer cases diagnosed, and with an incidence almost close to 3,000 per 1 million. Going to children, the number per year is about 400,000 for those who are aged below 18 years. If we divide the incidence between below 14, 50 to 100 per million, but it will be doubled if we consider adolescent group. The second fact that's saying that though childhood cancer is rare, but it is a common cause of death. And that's true for both pediatric children as well as adults. So cancer is the second cause of death after accidents, and in adults it's the second cause after cardiovascular disease. Every day there will be at least 240 children die of cancer, with an annual estimate of 90,000 per year. But the third fact saying that in spite of this statistics, still it's not the whole story, because the problem that in low income and middle income countries, which are colored here by red, yellow and orange, in these countries there is no accurate records, and maybe many children are dying even without being diagnosed. So the current numbers are underestimated. Then the majority of children with cancer are coming actually from low income and middle income countries, which are almost 80% of them coming from these countries. And this is important when we talk later about the survivor and how this is affecting by that. The fifth fact saying that childhood cancer is not one disease, and it can grow in any organ or cell. So it can grow in any organ, as we said, from the brain down to the all limbs and in the blood as well, in the bloodstream. So if we go to know the subtypes and different types of cancer, it depends on the age. So if we select below 14 years, the most common childhood cancer is leukemia, represent 1/3, followed by CNS tumors, almost 1/4, and then lymphoma. So lymphoma, leukemia, we call them hematologic malignancy. This is followed by what we call them embryonal cancers, which are including neuroblastoma, retinoblastoma, renal worms, and hepatoblastoma. And then other type of cancer. If you look here at this green color, this is what we call it the carcinoma, melanoma, which are represent the type of cancer in adult. So it is very small percentage here. If we consider adolescent group, because many times adolescent also treated under pediatric care, so the percentage is changed, and still here the hematologic malignancy is a little bit less. Brain tumor still it is high, but we can see that embryonal tumors are coming less and more of germ cell tumor, bone tumor, and here the adult type of cancer is start to increasing. The next fact saying that even neonates and infants can get cancer, and still this age are also at risk to develop cancer, though the type of cancer at this age is different. So in neonate and infant, we can see that leukemia, which is the most common seen, as they are less representative here, but more of cases are coming from the embryonal type of tumor. So neuroblastoma is more common, though it is of low risk, and many of them, they resolve spontaneously. Then we have the renal tumor, liver, and also retinoblastoma. The same is here, but with different percentage. The seventh fact saying that childhood cancer is biologically different from adult cancer. And this is one of the difference between them. So this cartoon showing in a quick the difference. So this is the previous figure, hematologic malignancy here, here the brain tumor, and then here the embryonal, followed by others. If we go to adults more than 30 years, we can see that majority are of the carcinoma, which are involving the breast cancer, lung cancer, colon, prostate, and thyroid as well, and others. While the hematologic malignancy are representing very small here. And in the age which we call them adolescent and young adult, AYA, the percentage are in between. Carcinoma almost 50%, and we have more of germ cell tumor here. If we come to the causes of cancer, it is still unclear why children get cancer in most cases. If you remember in adult, if you know in adult that there are several factors. We have environmental factors, we have genetics which could be inherited or acquired through the effect environment factor, and some people, they have no clear risk factors. Environment factors in adults represent very important risk factors, almost responsible about 50% of adult cancer. What are these environmental factors? We have the smoking, which is the most common cause for it, for many different types of cancers, the unhealthy lifestyle, unhealthy food, less physical activity, obesity. We have exposures to pollutions, chemicals, viruses. As we know, we have the hepatitis B, C, and we have also HIV and papilloma virus, ionizing radiation, and we have the ultraviolet and its association with skin cancer. If we come to children, the causes here, we can see that in most of the cases, we are not sure exactly if there is any specific reason. Though still we have a genetic causes and we have environment. But we believe that the percentage of unknown causes, which is the 90%, they year by year are coming less because more discovery of genetics with the improvement in the genomics, and also more studies are studying the effect of environment. And this table represents a summary of some of the genetic risk factors that cause childhood cancer. We have what we call it familial neoplastic syndrome, which can cause familial retinoblastoma, familial Wilms tumor. Just last year, we had three members of one family to have Wilms tumor: mother, her brother, and one of her children as well. We have Lelofromani syndrome, which is associated with children and adult cancers as well. We have inherited immune deficiency. We have bone marrow failure like Fanconi. These patients, they are at risk to develop leukemia, lymphoma mainly, and they are rare, but I can tell you that I have seen an example of each of these diseases in Bahrain. We have several patients having these very rare inherited disorders. And we have also chromosome abnormality. Among them, the most common is Down syndrome. It's well known that Down syndrome, they have increased the risk of leukemia, specific type of leukemia, we call it AML, M7, in these patients in the first almost 5 years of life. If we come to environmental factors, there are some evidence that showing that it's playing a role for childhood cancer, because they found that the incidence of several childhood cancer like leukemia, brain tumor, epithelial neoplasm are increasing in the recent decades. And it's also variable among different countries or ethnic groups. This suggests that there is a role for environmental factors. Maybe it's also playing in association with genetics or by itself as a single factor. So when we come more about environmental factors, these factors play a role in children, but not to the same extent as in adults when we say they are responsible about 50%. But it is very well known that early exposure from the time of even preconception to fetal life, intrauterine, and early in childhood can make these kids at high risk to develop cancer by adolescent or even by later life. If we talk about smoking, as we know, there are more than 80 carcinogens in that. And if maternal smoking, even paternal smoking as well, they found that meta-analysis of more than 30 studies showing that parental smoking showed an increase in the risk by 10%. Ionizing radiation, the first time coming from studying the cases of cancers among the survivors of the Japanese atomic bomb. And we know also that exposure to ionizing radiation by X-ray, by multiple CTs can increase the risk as well. And this is very important to consider to minimize using it for unnecessary cases. And also, if these kids are exposed to radiotherapy during their early childhood, they can be at risk to develop within 10 years of any sort of cancer at the site of radiation. Ultraviolet radiation, with the exposure to a lot of people tend to expose to sun for changing their skin color, and in areas like Australia, there was a study showing many cases of melanoma and skin cancer in the adolescent age group because of that. Viruses, as it's well known, but in children, usually we have more of ABV association with lymphoma, and we have the chemical exposure. Most children are exposed, as well as adults, they are exposed to unhealthy levels of air pollutions, and because they are developing bodies, they are making them more sensitive for such pollutions. Some studies have shown that these particles increase the risk of certain types of cancer like leukemia, brain tumors, lymphoma, and embryonal tumors. As we know that air pollutions are found in outdoor and indoor. So in outdoor, we have many sources from the airplanes, from the transports. We have also from factories. We have from oil and gases, and also from natural occasions like volcanoes, from the heating process affecting as well and causing that air pollutions. For indoor, which are the area exposing these kids to carcinogens, there are chemicals coming from different sources, like from cookings, from also using printers and cleaning medications, from also the, as well known in our country, we are using a lot of bukhur or wood burning. These are all these mix of chemicals that can we known to be carcinogens. These are different names of these chemicals, and they are carcinogens because they can do DNA DNA damage, oxidative stress, and also chronic inflammations. The problem that house dust is a reservoir for such chemicals, and our kids will be exposed to these either by ingestion, inhalation, or even by skin contact because they are crawled in the ground. So just as a break, the second question is, what is the day of International Childhood Cancer? I thought we will, that's why, because September is the awareness month, but actually it's in February. If you remember, for adult cancer, it's the 4th of February. Children usually follow adults, so it is 15th of February. And continuing with the facts, fact number 9, early symptoms are often non-specific. And this is really one of the reasons behind there is some delay in diagnosing children. These symptoms can be summarized by using the acronym child cancer. We'll see in next slides. But it is very important to say that presence of these signs and symptoms not necessarily indicate that this child having cancer, but it should alert the parent to seek medical advice and also physician to consider cancer among the differential diagnosis. Because, as we said, cancer is rare, so there are other diseases like infections or inflammatory process more common, and we have to consider it. But we should not forget about possibility of cancer as well. In addition, that several cases are asymptomatic and can be discovered incidentally by the parent or by doctors for any during the routine checkup. For example, while bathing, the mother noticed a mass in the abdomen, and this is one of the common presentation of Wilms tumor, which usually doesn't cause other symptoms. So if we come to summarize these symptoms and using the acronym child cancer, we have C for continued unexplained weight loss or poor weight gaining, headache, which can be of any character, not necessarily to be in the morning, but it's most in the morning, but there are other types of headache. Increase or recurrent pain in any side of the body. We have also any lump in the body, in the neck, in the abdomen, and limb. We have to consider possibility of cancer of that. And we have also development of excessive bruising or bleeding. It's very common. I know that bruises are very common in children, especially when they start walking. But the appearance, especially in areas like in the arms, in the back, without having trauma, we should consider that could be a reason behind it, for example, leukemia. Rest of signs and symptoms, we have C for constant, frequent, persistent infection, or we have change in behavior. For example, it could be a sign of brain tumor. A whitish color behind, which is the leukocyria, which is one of the signs of retinoblastoma. And we have also nausea that persists or vomiting, constant paleness, and we have also any change in the eye or vision. So we have any acute incident of squint. We have swelling with the bruises around the eye. This is one of the signs, we call it raccoon eyes, seen in patients with neuroblastoma. And so these, what we call it, the red flag signs and symptoms or warning signs, has been summarized in such cartoon to make it easy with picture and to make it easy for the community as well as medical field. Fact number 10, saying that in spite of we are talking about cancer, but the good news that childhood cancer is a curable disease. When we come to adult, over years, there has been gradual improvement in the survivor of adult. It's reaching up to 55, maybe a little bit more now as well. But in children, over years, we can see there is increasing the survivor, and it's reaching to 85% almost as an average. So definitely, it is much better than in adult. And this is, it's also even some cases are reaching above 90%. For example, patients with Hodgkin lymphoma, Wilms tumor, leukemia, and we have cases below 70% for neuroblastoma and AML. So, and it continues improving. And so when we consider what are the causes of such improvement, what we call it the key elements of better survival. This tree, we call it the tree of life. The hands represent the survivor, and these roots are 10 roots, different color. Each color represents one of the key elements for a survivor. They are summarized in these points. We have the presence of a government policies, accurate diagnosis, effective treatment, multidisciplinary care, the presence of palliative and supportive care, family support, having a qualified workforce. We have availability of medicines, registry of cases, and rehabilitation integration for the survivors. What we mean by multidisciplinary, treating childhood cancer is not anymore one person show. It's a group of people coming together and treating these kids. So we have the pediatric oncology team, doctors and nurses. We have different surgical team, and surgical team not only pediatric. We have orthopedic, we have ENT, we have ophthalmology, we have thoracic, and we have also the radiation team, other specialties. We cannot work without annoying our colleagues in pediatrics. We need to annoy the BICU, the other specialties, respiratory, cardiovascular, for many things, assessment, ID as well. Of course, our anesthesia department most of the time because of our procedures, and many other specialties. And we have also, we need the income of our colleagues in the pathology and radiology to help us for diagnosis and to do some of the procedure. Other members of the team are palliative, clinical pharmacists, child play therapists, and social worker. Absence or weakness of any member of this team definitely will affect on the work as a whole and the care of these kids. And we have also the parents. They are a member of this team, making them knowing about the disease, sharing them, because they are the one who's going to look after the kids, especially at home, many hours. So they have to be aware what are the important signs to be alert to bring them back to the hospital. What we mean by supportive care is the policies that make sure that to give the proper and safe care for these kids. We have policies about chemo, guidelines about how to deal with emergencies, how to prevent infection, and one of the important emergencies we have fever, neutropenia, how to prevent complications, proper pain management, psychological nutrition, and also the role of NGO. And we notice it over the almost 11 years now, how they help us, help the patients, and help even the team to give the proper support for the patient. Just an example of how multidisciplinary team work. This lovely kid is now 13 years old. He was 10 years old in 2020. It was in the time of Corona. This boy was admitted in one of the hospital with history of cough, shortness of breath, and 1 week duration. And his examination showed some chest findings, and his chest X-ray was showing such changes there with the pleural effusions and some widening of mediastinum. And because he was started to be treated as a pneumonia, but because of this picture, a CT scan was done within 2 days, and it was Thursday afternoon when we received the call. Most of the complicated cases, I don't know why it's coming always in the end of the week and make us very busy with them. So we receive a call about him that there is a possibility that there is a mediastinal mass, which is one of the oncology emergency. So we arranged to receive him. It was within few hours, came by evening to pediatric oncology unit, and the repeated X-ray at that time showing progression of that. And this is not surprise because T-cell lymphoma is very progressing disease. Even the tumor cells can multiply in size every 24 to 48 hours. So this boy was within 2 hours of admission was seen by different subspecialties, PICU, cardiology, pediatric surgeon, thoracic surgeon, lab was informed, and anesthesia as well. And and started on small dose of steroids to keep him just stable and minimize intervention with them. Next day, he was intubated electively in theater, underwent 5 procedures together under the same GA, intercostal drainage for the fusion, biopsy of the tumor, port cath insertion, bone marrow, and lumbar puncture. We were able to do that all, and we saved him. Alhamdulillah, he responds very well to treatment, and he finished treatment after 3 years. He's more than a year now in a remission status. So survival rate differs significantly between low and middle income countries and high income. If you remember, this is the previous survival rate we said, but this is true only for high income countries, which are represented here by the blue colors. But when we come to the low income countries, the survival is much less than that. It's almost below 30%, and this is what we call it survivor gap.
Money gap.
Sorry?
This is the money gap.
Yeah. So what are the reasons for that? It's represented by here, this figure here, but they are summarized, as we said. They are exactly the opposite of what the key elements of survival. So awareness among them, very important. Wrong or delayed diagnosis, lack of access to treatment. Treatment costs, many countries, they have to pay, even in their countries. Alhamdulillah, in our country, the treatment is free for the patients. Refusal to be treated also, and when they have a weak health infrastructure. It's well known that true for adult as well as pediatric, that early diagnosis means better survival and better quality of life. Because patients, when they came in advanced stage, the disease is heavy burden, so is advanced. Even for very curable diseases like these diseases, when they come in advanced stage, the survival will be much less, because they have also to expose to very heavy treatment. Heavy treatment means more toxic effects, maybe more death and poor quality of life. Fact number 13 saying that childhood cancer cannot be prevented because we don't have very well-known strong non-risk factors. But deaths from cancer can be reduced or even prevented if cancer detected early. And how this happen? This is happening by awareness of parents. So we'll let them to seek medical advice early, and awareness of doctors to consider it as among the differential diagnosis and for early referral, because it's well known said that the eye doesn't see what the mind doesn't seek. So just will give you quick scenarios about such importance about such awareness. This is a 3-year-old girl presented to health centers with history of constipation of 2 weeks. Doctors concentrate on the diet and advise and start the patients on laxatives. Forgot very important things, maybe because of busy work, because few minutes in the health center they have to, and didn't put the hands on the abdomen. And these patients, those started on laxatives, responding sometimes, but his condition progressed, and after 3 months presented with more worsening of abdomen distension, and he was found to have a big tumor arising from his kidney. So it was a Wilms tumor. So this can be, and it was stage 3. Actually, he was presented with stage 4, even with metastasis. And if it was detected early, definitely his treatment will be less. He will not be exposed to radiation, and he will be finished treatment within short period. And survival will be better. A 6-year-old girl presented to health center again with hypoactivity and reduced appetite of 1 month. Assessed and found to be pale, no hepatosplenomegaly, nothing there. So suspected to have anemia. CBC done for HP by finger prick done, and it was HP was 7. Because of that history, suspected to have iron deficiency, which is a very common in children, and given iron with a follow-up after 2 months. But this child presented to emergency after 2 weeks with fever and petechia, and he was found to have this CBC, low HP, low platelet, and very high count, hyperleukocytosis as leukemia. And he was found to have tumor lysis and electrolyte imbalance. This patient, at least as CBC done initially, maybe will not consider iron deficiency as possibility. I will refer early to a hospital. 14-year-old boy presented with 1 year history of back pain. did different shopping medical advices because of history of trauma, so suspected because of trauma, X-ray was normal, given different physiotherapy sessions and analgesia, but by the end of 1 year, start to have some weakness in their limbs, and an MRI done and was showing a spinal tumor there. So back pain in children is very rare complaint. In adults, many times we have back pain, but in children should be considered, even if there is history of trauma, it should not last for a year. 12 years old girl had different attacks of headache for the last 3 months. She doesn't have any other issues, normal in examination, positive family history of migraine, and as well as she was using her mobile a lot. So because of that, and because of her examination was normal, she was diagnosed to have migraine and started on some treatment and reassured. But this patient, after several months, her headache became more, and she started to have vision issues and found to have brain tumor. It doesn't mean that any headache in children is a brain tumor, but it's something need to be, for example, we should not give a diagnosis of migraine unless we rule out or at least close follow-up to see such patients. Factor number 14 saying that systemic screening for childhood cancer is not practical and not cost effective. We know that for adults, for example, for females, we have the screening for breast cancer. We have target group. Females above the age of 40 or those who have positive family history, and we have a screening tool which is ultrasound and MRI, and it's a common disease. Other cancers like colon, we have also sub-screening, but for children, we don't have a specific tool, and we have many different types of cancer, so screening is not practical and not cost effective. But what will they find that targeted programs promoting early identification and referral is very important for in the field of these diseases. And that's why the WHO has launched at least 2 programs for the last several years in order to improve this referral. We have what we call Child Cancer Smart, having this list of signs and symptoms, and we have also last year or 2 years back started what we have program called SIOP, CDAR, Child Earlier Disease and Referral, early detection and referral, and they concentrate on the most common 6 types of cancer which are very curable: ALL, Burkitt, Hodgkin lymphoma, retinoblastoma, Wilms, and low grade. These are responsible about almost 50 to 60% of childhood cancer. If we improve the awareness of people about these diseases, they found that they can improve their survival in low-income countries from below 30 to 60%, and within the coming decade, they can save a life of 1 million. And actually, that's our project now. In the coming 2 years, we are going to have a series of such presentation about diseases, and our presentation today is the first session of that. The fact before the last one is saying that if a cure is not possible, and this is possible in about 15 to 20% of childhood cancer, then we have to change our goal from curative to the best quality of care for these patients, and that's exactly what we define it as palliative. Comfort focus should start from the beginning, increase with time, in addition to give the psychological spiritual support and to minimize any physical suffering for children to have a good quality of life even around the time of death as well. Actually, palliative care is now seen as both the right of the child and also indicator of a good quality healthcare system. The journey of cancer doesn't end with end of treatment, but it continues with the journey of survivor. This is one of our lovely survivors, graduated from university maybe 3 years back. I think he's working now, and he's a fighter. That's exactly, they are very fighters, and they taught us also to be fighter for them. Why we have concern about survivor? Because they're exposed to heavy treatment, including high-dose chemo, radiotherapy, bone marrow transplant, and these heavy treatment make them at risk to develop not only side effects during treatment, but long-term effects that can appear even after years, including cognitive, psychological, hormonal, fertility, second neoplasm, and also cardiopulmonary. That's why these patients need to be followed in a special clinic. We call it the long-term follow-up clinics, and to be sure that they are doing fine, even at least once a year or every 2 years later. And that's why also, in order to minimize this long-term side effects, the treatment now has shifting from cure for any cost to greater focus on the quality of care. That's what, for example, if we have now leukemia, ALL, we have 3 groups. We have low risk, intermediate risk, high risk, and we treat them with different intensity of treatment to minimize the toxicities in those who are responding to the minimum toxic medication. Another question, which day is the Cancer Survivor Day? Any guess? It's June, yes, going away from September. It's true, it's the first Sunday in Western countries, Friday in our country of June. We are looking the next June of 25, we are going to have big celebrations for survivors. Just 3 weeks back, Smile Initiative did a celebrations for 40 patients of our survivors. And when we say survivor, they are at least finished 5 years from off treatment and remission status. I think through all the previous slides, we are now aware about what we call childhood cancer pathway. So we have the early detection to diagnosis to treatment to survivor and different elements. I just want to concentrate on the last slide about that onset, when we have from the time between the onset of symptom to the time of first medical seeking, we call it the patient time, and awareness of parents is very important on that to make it very short. When we, the time between medical seeking to referral to oncology center or unit, we call it the referral time. It depends on awareness of the primary care or any physician who see the patients as first line consultations and having a high index of suspicion, and when there is a good referral system. We'll talk later about what is the referral system here. And the time from reaching to the pediatric oncology to the diagnosis, we call it the diagnosis time, depend on the MDT approach and resources, and then we have the treatment time. The goal is to minimize this duration, to make it as short as possible in order to not to treat patients and with the minimum effects of missing or getting an advanced disease. So how we can help these kids? The responsibility is not only in the Ministry of Health or the health system or the decision makers in the country. It is a responsibility of everyone. If we talk about the health system, we need to have everywhere a good infrastructure resources. We need to have a very good referral pathway to short the time for referral and diagnosis, good registry, improve education and training. We need to encourage the new generations of doctors, nurses, and other health to consider oncology and all the others, even surgery, lab, which are as part of their career to help these kids, because we notice there is a refusal or avoidance to be specialists in such field. And also the importance of having palliative care program. Palliative is not only for oncology patients. Palliative will help every disease that has no cure or very long or can lead to death. From community or from hobby, every individual has a role. Just raising awareness and correcting the misconceptions, taking this information to teach your family, your relatives is a big role. Having high index of suspicions and early referral to centers. Also, teaching ourselves to follow a healthy life, and also be sure that our kids follow a healthy lives from early in order to prevent cancers in them later or during adult life. Supporting the NGO as well, because they have big role in supporting patients. Private sectors like banks, companies, they can support research and support the expensive cost of treatment as well. And support survivors to be effective members in the family and support parents as well. This is one of the activities was done with SMILE in 22 together with the government hospital, having a stand and a lot of brochures and awareness about childhood cancer. So the take-home message, remember that children are not small adults. Remember what we call it the childhood cancer pathway, and the survivor or the tree of life. And remember what we call the pediatric cancer survivor gap and the causes behind it. And through all hands, individual, hospitals, companies, every private sections, we can improve the diagnosis, care, cure of children all over and close the survivor gap. We can also give the best quality of care to every child, even those who are dying. We have to be sure we're giving them the best care. Thank you very much. And before that, sorry, this is the theme of the International Childhood Cancer of this year and for the coming 2 years, saying that better and equal access to care for all children and adolescents with cancer everywhere. Thank you for your silence and your support, and welcome for any comment and question.